Good afternoon, everyone. Thank you for joining today's webinar. I'll go over a few things to note as we get ready to get started. First, participants will be muted upon entry and videos turned off. For technical assistance, please use the chat feature. Third, you will receive an email approximately 1 month from today requesting feedback and impact on today's presentation. Next, we ask that you visit www.ncdus.org/training to view other training opportunities. Today's session will be recorded and provided via our NC Training Center. I'll now go ahead and introduce today's speaker. Today's speaker is Dr. Martha Perry, the Chief of the Adolescent Medicine Section in the Division of General Pediatrics and Adolescent Medicine at the UNC School of Medicine. As a board-certified adolescent medicine specialist, she provides care for adolescents and young adults with complex medical and psychosocial needs. She completed pediatrics residency at Boston Children's Hospital and adolescent medicine fellowship at UCSF. She has experience working with multiple clinical environments, including school-based health centers, community-based health centers, private practice, and most recently in the academic setting. Her research and teaching focuses on access to reproductive and sexual health, as well as ensuring consent and confidentiality, particularly in marginalized youth. She joined UNC in 2017 to develop a clinical adolescent medicine program, which now provides outpatient specialty care in Greensboro, Chapel Hill, Raleigh, and Sanford areas, and inpatient consultation care at UNC Children's Hospital and UNC Rex Hospital. I'll now turn things over to Dr. Martha Perry.
Thank you very much. And it's great to be here today and to talk about a very important topic, which relates to weight and really stigma associated with weight and how we as care providers can talk to patients in a way that is less stigmatizing. The objectives for today really are to ensure that those of you with us leave with a little bit of understanding of the history of BMI, body mass index, as a measure of health, and identify stigmatizing behaviors and interventions that might be focused on weight when in reality we may be able to be focused on other approaches. Finally, we'll talk about some ways to address weight and eating behaviors in using non-stigmatizing strategies as we close out today's discussion. I do hope that we'll have some time for questions as well, and certainly welcome questions in the chat, as Lachelle already mentioned. First, let's talk a little bit about where the BMI comes from. So there is a formula, this is a formula that was actually developed in 1847 by a statistician and astronomer, Adolf Quetelet, as a means of studying populations. And part of it was really just to understand how much space people take up and to better understand where people fit on the planet and within our population. In 1972, Ansel Keys, who's well known for the Minnesota Men's Health Study that evaluated effects of starvation in conscious objectors during World War II, proposed using Quetelet's formula, which is BMI, weight over height squared, as a weight index. And that's when he coined the term body mass index to identify individuals with excessive adiposity. An important piece, though, if you read his original article from 1972, which was reprinted in 2014, is that he gave an important caveat, which is that it is unlikely that any weight index will provide an acceptable indication of adiposity or body fatness. The weight indices were originally used for life insurance assessment and published as a means of determining both acceptability for life insurance and rates of life insurance. And Keys really criticized this use of weight and some other weight indices that were less accurate, stating that they really weren't an assessment of fatness or health risk. He proposed at that time using body mass index, but it wasn't really until the 1990s when the World Health Organization shifted to body mass index that his work was taken into account and used differently. And that's when, around 1995, categories were determined by an expert panel classifying individuals based on BMI as underweight, normal weight, overweight, and obese. And literally overnight, people that hadn't previously been considered overweight or obese were suddenly classified as such. And we began as a society really emphasizing weight even more than we had prior to the 1990s, emphasizing weight as a sign of health, and being overweight or underweight as being a sign of health. It began to be used to categorize and define degree of adiposity. And typically, in adults anyway, a BMI of greater than 30 kilogram per meter squared was defined as obese or defined as obesity. It really ignores as a tool the complexity of weight gain, such as overall body composition, as well as location of adipose tissue. For example, there are more health risks associated with adipose tissue that is abdominal as opposed to other parts of the body. The medical establishment now, of which I am a part, widely promotes the association between obesity and multiple medical problems, although there are confounders and bias that suggest more complexity. And in fact, while we know that modest weight loss appears to reduce mortality when there are comorbidities such as diabetes or hypertension or high cholesterol, that is not true in healthy individuals who are defined as overweight. And in fact, it may be harmful for those individuals to attempt weight loss when they don't have existing comorbidities. And we're going to explore that more as we go. One of the really important recent studies was in 2016, where Tamiyama and colleagues examined NHANES data from 2005 to 2012 and revealed that more than 74 million individuals would be misclassified if we relied solely on BMI to determine their overall health status. Individuals were actually metabolically healthy, but had been labeled as unhealthy because they fit into the overweight category. So almost half of individuals who are overweight, when their blood pressure, triglyceride, cholesterol, and other markers were checked, they were deemed metabolically healthy. And therefore, if we use BMI solely as a tool to identify individuals as healthy or unhealthy, we are misclassifying half of overweight individuals. We're misclassifying almost a third of obese individuals and 16% of obese individuals who fit into type 3 or 2 categories, which are considered the higher range of obese in those categories. And then what's really important is that 30% of what would be considered normal weight individuals were metabolically unhealthy. So this team really proposed that we need to start thinking about more accurate markers of health. Those might include physical activity, cardiorespiratory fitness, waist circumference, body composition, and other biomarkers as the ones that they used, such as blood pressure, triglyceride, cholesterol, glucose, insulin resistance, and C-reactive protein. What that leads me to is the important piece of weight stigma. That's defined as negative attitudes and beliefs that devalue people based on their weight status, resulting in labeling, stereotype, and discrimination. We know that stigma in a variety of different ways, whether it's weight-based or race-based or gender-based, has an impact on individuals' psychological and physiological health. But there is still a lot to learn about the impact of stigma on weight. And despite genetic, biologic, and environmental drivers of weight regulation, there's a public perception and even policies in existence that emphasize personal responsibility for weight and associate overweight and obesity with individual behaviors as opposed to those genetic, biologic, and environmental drivers. In fact, about 40 to 50% of adults who are categorized according to BMI as overweight or obese report internalized weight bias. They have negative feelings towards themselves based on their weight because of some of these attitudes that are pervasive in our society. And 71% of US adolescents report being bullied about their weight in the past year. In addition, many of you, I'm sure, have seen that weight stigma is quite prominent on social media. It was already there, but with COVID-19, it skyrocketed. Everywhere you looked, you saw that hashtag quarantine15, and you started to see increasing numbers of videos and increasing advertisements for quick fixes and dramatic before and after photos to deal with that quarantine 15. There is a documented relationship between social media and disordered eating behaviors, and this became worse as we entered the pandemic and continues to be problematic as individuals look for those quick fixes and see those dramatic before and after photos, wishing that they too could have such results. Oftentimes, again, those are false advertising and photos that have been airbrushed or in some way doctored to reflect a false result. In addition, we have an increased likelihood of online weight-based bullying. Individuals are much more likely to express themselves through online means when there's more anonymity associated. And when analyzing comments made on Twitter and other social media platforms, there's unfortunately quite a bit of weight shaming that occurs more substantially, unfortunately, than weight positive feedback that occurs on social media. I'll talk a little bit more about some ways to find positive sources of social media, which do exist. And it's important to point out that there are both positive and negative aspects of social media that overall contribute to body image. Another really important piece is the social media algorithms that really focus on individuals' searches and identify sources to promote for those individuals that may not necessarily reflect those individuals' needs. So teenagers may be exposed to more weight loss promotion and may have decreased exposure to body positive influencers because of their searches on Google or their searches on Instagram or other social media platforms. There's probably many more than I'm mentioning because I'm starting to feel old and not know all of those platforms as well. I will say that myself, being on Instagram for my job and to monitor my now young adult and teenage children, I find that I get frequent advertisements for how to lose weight during menopause, which fits. I'm in my 50s, and so I'm getting all these advertisements about ways in which I can improve my eating habits and lose weight due to weight gain associated with menopause. Well, there's metabolic and important reasons for gaining that weight, so I really would rather not have those advertisements. Unfortunately, the other piece that I think is really important is that as social media platforms develop these algorithms, they do look for ways to eliminate both race and gender bias and other biases that are presented by individuals, but there's not a lot of weight stigma in the algorithms currently to prevent folks from posting things that are particularly stigmatizing and negative. So when we think about the impact of weight stigma and discrimination, what we know is that with any form of stigma, as I mentioned before, an individual is under chronic stress, and this can result in really significant worsening of psychological well-being. About 30 to 40% of impaired psychological well-being is attributed to weight discrimination. So not related to the individual's body image or the weight themselves, but related to their experience of weight stigma and experiencing discrimination based on their weight. This results in depressed mood, low self-esteem, increased risk of substance use, ways to escape and to cope with significant stigma they're experiencing in their everyday life. Sometimes it can result in exercise avoidance as individuals feel some degree of shame or feel embarrassed if something has occurred in the gym or in other environments. It can result in a delay in seeking healthcare, and I'll talk a little bit more about that. I'll show you a little bit about disordered eating behaviors and the increase that we see there. And unfortunately, a transition from overweight to obese. So what we see is individuals may have some weight gain. We naturally gain weight throughout our life. It's normal part of the process. individuals may experience weight stigma, some who are in what would be categorized as normal weight, some who are categorized as overweight or in larger bodies. I really prefer to use terms other than overweight or obese. And so I will try to use mainly terms such as larger bodies, smaller bodies, but try to not categorize bodies at all by size. However, a lot of the work that I'm reviewing today does refer to weight using words such as obesity or overweight. And so you will notice me using those from time to time based on how things were described in the literature that I reviewed in preparation for today. So as you see, we have this cycle where individuals experience weight stigma. This causes chronic stress. This sometimes can lead to, or frequently can lead to, disordered eating behaviors, particularly binge eating. This may result in weight gain. This may result in further weight stigma, and we get stuck in a cycle. And there's many folks, myself included, who believe that a lot of the increase that we're seeing in body size relates to these recurrent experiences with weight stigma, chronic stress, disordered eating behaviors, and ineffective dieting that results in ongoing weight gain. It's important also to understand the physiologic harm that we see with individuals who experience weight stigma and weight discrimination. We know that increased inflammatory markers are associated with discrimination. In fact, individuals had a higher CRP when they were in a BMI of around 30 when they reported weight discrimination. What's interesting is that we see that in individuals in the range between 25 to 30, which is called, depending on what resource you're looking at, it's called overweight or pre-obese or different elevated BMI, different categorizations. But what's interesting is that those individuals in particular are labeled, when labeled or experience weight stigma or weight discrimination, have a higher likelihood of experiencing increased inflammatory markers, which ultimately is going to cause damage to their cardiovascular system and increase their risk for a variety of problems, including hypertension, hyperglycemia or diabetes, insulin resistance, which then can lead to diabetes, and hyperlipidemia. There's in fact a randomized controlled trial where individuals were exposed to stigmatizing comments and then subsequently had measured levels of cortisol as well as other factors such as blood pressure, and those were noted to increase when exposed to those stigmatizing comments. There's multiple studies that suggest this perceived weight discrimination is associated with glucose dysregulation and chronic inflammation that leads to a lot of the complications that are attributed to obesity or attributed to being in larger bodies. And so what I will say is I'm not saying that being in a larger body doesn't cause or contribute in some way to the comorbidities that we're seeing, but it gets over attributed. A good example is the combined pooling of data with the MIDAS study, Midlife in the United States, and the Health and Retirement study, where individuals were interviewed about weight discrimination and evaluated over time. And what they saw was that weight discrimination was associated with 60% mortality risk when controlling for other physical and psychological risk factors, meaning that a large majority of those who were in larger bodies and experienced weight discrimination had a higher mortality risk than individuals who did not experience that, who were also in larger bodies. This risk, interestingly, was higher than most other forms of discrimination, including race and gender. It was very similar to individuals who experienced discrimination related to physical disability. And what's interesting is that there has been some debate and suggestion that obesity be labeled as a physical disability or as some kind of disability. And part of that is because the concern is that individuals don't have access to the care or rights that they need to, or that they have experienced discrimination without as much recourse as other individuals who are labeled as disabled. However, there's a good amount of suggestion that individuals labeled as disabled experience discrimination, and that further labeling individuals who are in larger bodies as disabled or labeling them in other ways may unfortunately cause further stigma and further discrimination. Weight stigma in healthcare is something I want to spend a little bit of time focusing on. In the UK, about 88% of people reported weight-based stigma occurring when they saw their medical provider. 42% felt uncomfortable discussing weight with their doctor, and only a third really, reported being treated with dignity and respect by their doctor when seeking help for their weight. Physicians are the second most common source of weight stigma when individuals are evaluated in a variety of different ways and share where they experience the most stigma. Unfortunately, number one is typically family, but number two are physicians. Physicians report a lack of training and low confidence in nutrition knowledge and typically spend maybe 2 to 3 minutes per visit maximum on nutrition counseling. This was actually seen in several studies, one looking at cardiologists and one looking at cardiologists and internal medicine physicians. Only about a quarter of medical schools offer the recommended 25 hours of nutrition training. I think I got 4 hours when I was in medical school, maybe less. It might have just been an hour lecture. And only about 20% of physicians report themselves meeting the recommended 5-a-day fruit and veggie intake. So one of my concerns is that we have physicians recommending nutrition changes to improve health when maybe those individuals don't need to improve health. And those physicians themselves may not be able to follow those recommended daily routines to a degree that they're recommending to their patients. Also, we see that referral rates to dietitians, particularly among adult providers, are very low, and particularly among cardiologists. Certainly, we know that there's some weight stigma that occurs with dietitians as well. It is lower, however, than other healthcare providers. And so certainly I would, and certainly given the level of training related to nutrition, I would certainly rather, if there's a significant nutrition issue, that dietitians be involved. And from an evidence-based perspective, as we think about things like eating disorders, that's certainly a critical part of individuals' overall care. So healthcare individuals, unfortunately, describe individuals living with obesity as lazy or non-compliant, lacking willpower, being undisciplined. About 69% of physicians, 46% of nurses, and 37% of dietitians demonstrate weight bias. Physicians in particular report care of individuals with obesity is less worthwhile than individuals viewed as thinner. So what we know happens based on report of individuals as well as observational studies is that individuals in larger bodies have less time with providers, have less health education, subsequently have less trust in providers, and subsequently then less access to health. They may be less likely to disclose things to their providers, or they may be less likely to seek care altogether based on their experiences with health providers, and subsequently have worse health outcomes. So again, I go back to that statement early on where I talked about the association between larger bodies and health. How much of that is being in a larger body and how much of that are these other factors? For example, not having access to the same kind of healthcare that others who are not in larger bodies have, or not being able to access care altogether because of fear of stigma, or the stress experienced with a stigma when it occurs both in the healthcare setting as well as with family or in one's own community. When individuals do get guidance from their physicians, it's oftentimes related to weight loss. And we need to talk a little bit about the consequences of dieting and the consequences of aiming for weight loss. Typically, dieting is defined as a change in food variety, amount, or frequency. It's usually associated with a decrease in caloric intake. Oftentimes, it has people restricting to about 1,200 or 1,500 calories per day. And interestingly, there was a medical school that asked all of their medical students to restrict to that degree of caloric intake, and many of them expressed significant psychological distress during that time, as well as difficulty concentrating and overall poor executive function. Numerous studies demonstrate the association between attempted loss and future weight gain. There's a variety of different theories as to why this occurs, But restrictive eating is often followed by hyperphagia or overcompensation. This may be, although it hasn't been 100% proven, related to leptin. When individuals are, the hormone leptin, when individuals are fasting or are partially fasting or restricting, their leptin levels may become lower. And this may cause them to have increased hunger and less ability to monitor their own hunger cues when they do start or resume eating once again. So we see individuals that have short-term weight loss results. This is sometimes the pattern after seeing physicians who point out, hey, I think you might need to lose weight. They attempt to lose weight. They might briefly lose weight, but then often this results in a higher weight in the long term and also may result in eating disorders. And we'll talk a little bit more about that. Recognition of disordered eating, particularly anorexia or nervosa, is often delayed or missed when co-occurring with overweight and obesity. This has been particularly prevalent currently with the pandemic in individuals who attempted weight loss at home. We're seeing an increase in what we would describe as atypical anorexia nervosa. So individuals that are quote unquote normal weight, however, have been restricting to a degree that they have physiologic consequences and are quite ill. So I've sometimes had a hard time convincing my colleagues that patients that are in what's considered a normal weight or even potentially larger body need to be in the hospital because of excessively low heart rate or other complications associated with their eating disorder. It's important to note that about 36% of adolescents treated for restrictive eating disorders actually were previously obese, and oftentimes start restricting or start dieting as a result of bullying, comments made either by family or by their, unfortunately, their physicians or medical team. And what we know is that disordered eating in particular, when it's preceded by, it is typically preceded by weight loss attempts, is often self-directed. So if a healthcare provider is supervising it as opposed to recommending it and the individual then attempts to lose weight, there is a higher likelihood that there's a lower likelihood, that they will develop an eating disorder. However, self-directed weight loss is more frequently associated with either an eating disorder or disordered eating. This is a study done in South Australia, where they do a very good job of monitoring and treating eating disorders. And what's important to highlight here is the trend. On the bottom, you'll see predicted prevalence of the various categories on the side. And again, this is the wording that was used in the publication. So obesity with very strict dieting or fasting, obesity with binge eating, purging alone, which would then be considered in a body that's not defined as obese, very strict dieting or fasting, binge eating, and obesity. And what you'll see is that when you compare 1995 to 2005 to 2015, we've seen an increase in prevalence of obesity and simultaneously an increase in prevalence of disordered eating. Binge eating in particular, and binge eating in particular in individuals who are categorized in this study as obese. So important to note that as we see an increase in obesity, we're seeing an increase in disordered eating. As we emphasize the importance of weight, or as some individuals emphasize the importance of weight and health and the importance of weight as it pertains to appearance, we've started to see an increase also in disordered eating and development of full-fledged eating disorders. So really what I want to do is look at this image where we see weight stigma at the center and we see mental well-being and physical well-being. I think a lot of healthcare providers in particular would look at this and say that you could make the same image with weight alone. And that weight alone contributes to issues with mental well-being and issues with physical well-being. And I hope that some of the evidence that I've presented today helps all of us think more broadly about the impact that weight stigma has on mental well-being and physical well-being. Knowing that it's been well documented that other forms of stigma and discrimination, as we start understanding better and better adverse childhood events that occur, those particularly related to racism or related to other forms of chronic stress, have a direct physiologic impact on individuals and direct impact on their long-term health. Weight stigma needs to be considered as part of that, weight stigma and discrimination. So remembering that weight stigma is contributing to anxiety, body image issues, increased risk of substance use, depression, low self-esteem, damage to our arteries, elevated blood pressure, increased inflammatory markers like C-reactive protein, increased cortisol, and increased hemoglobin A1C, which is associated with diabetes. All of these are indicators that weight alone is not the only contributor to the health outcomes that are so often referenced as we think about long-term health and weight. So when we think about a non-stigmatizing approach, we want to think, or at least I think about weight as a spectrum and not discrete categories. I avoid ever categorizing patients, other than when I'm having this discussion right now, as underweight or overweight. I may talk about patients who are malnourished, and an individual can be malnourished in any size body. But really important is ensuring that we have equal access to care along the entire spectrum. We want to ensure that we create inclusive surroundings. We work hard to do that in a variety of different ways related to gender, related to sexuality, related to race. We need to do that related to other areas, in particular related to size and shape. We need to ensure that our equipment is easily accessible and usable, whether it's checking a weight if that's necessary, or whether it's checking a blood pressure, or having the appropriately sized chairs or gowns, or the appropriately sized examination table. One of the important things we want to do is avoid having something that's in the drawer and only pulled out when it's absolutely needed. We really want to ensure that we're not making someone feel singled out, and that we're increasing our, that we're having to stop everything and get a different size related to their size. One of the most important things is staff and provider education. Knowledge alone is insufficient. We need to understand our own biases. We need to understand our own implicit and explicit biases. The Harvard Project Implicit is a great site that's free to go to, that you can access to look at whether you have biases. I have checked myself, and I do have biases, including weight bias. I work very hard not to have that, but I also acknowledge that we all have biases, and being aware of them is really important. I think individuals assume that they don't have those. When you go through some of the tests on this website, you will find out some very interesting things. I even apparently have a gender bias, which was actually quite surprising to me. When it comes to checking weight, this is something that triggers a lot of questions, but when I go to the doctor, they always want to weigh me before they do anything else. And I typically will ask if it's necessary. And usually I get strange looks when I do that. I think for patients that may not have the agenda that I might have with that, it may be even harder to do that. So I encourage you, if you're working with patients that are working on recovering from an eating disorder, or patients that any patient that doesn't want their weight checked unless it's medically necessary, that they have a card to take with them like that displayed here. Don't weigh me unless it's really medically necessary. Is weighing me today going to change medical management? Most of the time, it is not. If you're monitoring someone in the adult population, for example, who might have a tendency to retain fluid because they have chronic heart disease and they have heart failure, that may be very important because you need to know how much fluid they're retaining. But most times, weight does not contribute ultimately to the decision making, or at least it shouldn't. There are other factors, as we've talked about, that are going to be more significant and important in terms of really understanding an individual's health. In children and adolescents, it's a little more complicated. We do need to monitor their overall growth trend. And in adults, to some degree, on occasion, we need to better understand if there's been a dramatic change. But in adolescents and children in particular, we want to make sure that their height and weight are continuing to increase as they're getting older, and recognize when there's a delay or when there's rapid progression so that we can investigate that deviation, ensure that we're not dealing with a thyroid problem or another kind of metabolic or endocrine problem. So it is something that we need to monitor, but I try to look at the trend and then otherwise not really discuss it with my patients at all, unless it comes up in other ways. Some folks feel more strongly, and there are studies that have looking at the growth curve together with patients and families. There are mixed results related to that, but certainly some that suggest stigma. And as I'll discuss a little bit more, there are other ways to address health that might have an impact on that weight trend that you're noticing if you're concerned about it. So I suggest a universal approach when it comes to overall well-being. We need to talk about sleep. We need to talk about water intake. We need to talk about body movement. We need to talk about nutrition and stress reduction. Oftentimes, nutrition becomes a focus when an individual is in a larger body or when there's a trend that concerns a provider. This is often, honestly, especially with eating disorders, this is catching something rather late. So individuals may demonstrate disordered eating behaviors or other nutrition issues far before you're going to see a change on the growth curve or a significant change on the growth curve. So really thinking about asking every individual about their overall well-being with nutrition lumped into that can be much more beneficial than waiting and only asking those when you're noticing a trend weight-wise. The other piece that becomes really important is screening for depression and anxiety, which are both now recommended in adolescents, and not yet recommended, but hopefully something that providers will increasingly do is screening for eating disorders. There are multiple times when we see patients who presented with symptoms of an eating disorder well before, as I mentioned, they presented with behaviors of an eating disorder well before they present with symptoms of an eating disorder. And the earlier we intervene with eating disorders, the better the long-term outcome. I do know that the SCOFF, which is validated in adults, is available through NSEED and something that could be considered with adults, as well as could be trialed and considered for use in teenagers as well. Counseling all patients regarding social media pitfalls and risks associated with dieting is really important. It's probably not going to make a dent in the amount of social media that gets pummeled their way, but still important to point out to parents, patients as well, that their children or themselves are being bombarded with social media images or advertising that's promoting a diet industry, partly to make money and partly because of some of the fat phobia that does exist within our society. There's some body positive social media and online resources that I refer patients to. I've listed 2 websites here that individuals could go to. I really would want you to explore these websites yourself and decide what you feel comfortable with recommending to your patients or clients, but wanted to share with you somewhere that you can go to where there's lists providing additional information for body positive focused media. When I'm talking about overall well-being with patients, I'll say, as your provider, I want to support you in any way possible to live long and prosper, to do all the things that you want to do. While there are many things we can't control, we can talk about forms of self-care that might be beneficial to you. This typically includes sleep, water intake, body movement, nutrition, and stress reduction. What areas of self-care would you like to talk about today? This puts it in the patient's court in terms of what's going to be important to them and setting a goal or talking about an area that would be beneficial to them, and doesn't make it only about weight. It doesn't make it only about sleep. They can decide if there's an area that they want to talk to. Sometimes my patients say, I want to talk about all of it. Sometimes my patients say, I don't want to talk about any of it. And either way, that's okay. Ultimately, it's up to them. I also think, though, in this statement, a really important part of this is acknowledging that there's things we can't control. So often, individuals living in larger bodies who are identified as obese feel like others view them as being in more control than they are. And so acknowledging that there's a lack of control on many factors, genetic, biologic, environmental, becomes really important in talking to patients about their overall well-being and self-care. Well, what do you do when a patient asks about weight? So typically, I don't bring weight up. I talk about well-being as a whole. If I'm seeing a patient for an eating disorder, I do talk about weight. That's a whole different conversation. But in general, if I'm seeing a patient for a variety of different concerns or seeing them for a well visit, I really am focused on well-being, asking about all those different factors that I mentioned. If someone asks me about their weight, or a parent of a teenager asks me about their child's weight, I'll ask them first, well, tell me what makes you concerned about weight, and find out what it might be. And then I'll respond, sounds like you are concerned about weight and the risk of developing diabetes. There are many factors that can increase risk of diabetes, some that we can control, some that we can't. I'm glad you're concerned about your health and want to prevent health problems like diabetes. Rather than talking about weight, can we talk about ways to reduce the risk of diabetes? And then I'll talk a little bit about why focusing on weight might be detrimental. I'll talk a little bit about the fact that attempts to lose weight and a focus on weight loss ultimately can lead to weight gain later, or can lead to eating disorders, or both. And that really we want to focus on overall wellness, taking good care of our bodies as best we can. When patients are still pushing and they want to still talk about weight, or they want to still talk about nutrition, oftentimes I'll review a 24-hour recall and discuss some basic nutrition guidance. This might be related to fruits and vegetables, or it might be related to whole grains, or might be related to water versus sugar sweetened beverages. And again, I'll talk about it from a health perspective. For example, when it comes to talking about fluid intake, I'll talk about avoiding sugar sweetened beverages, not necessarily because of how it affects weight, although it can, but more so in terms of also how it affects teeth. And so remembering that some of the things that we avoid, that we consider less nutritious, are foods that have impacts beyond just weight. If the patient wants additional guidance, I really would encourage folks to consider referring to a body positive dietitian, and knowing who's in your area and who's body positive is really important. I've certainly had mostly good luck, but occasionally I've had some patients, even with eating disorders, who are matched with a dietitian that's very focused on body size and shape, which we really want to try to de-emphasize and focus more on overall nutrition and well-being. One thing that I found very interesting as I reviewed and prepared for this lecture is that patients actually like when their providers share their own challenges and solutions and acknowledge their own vulnerability. So keep it real, share your own challenges and solutions. I often talk about this related to water, because I know drinking water is really important and I'm terrible at it. And I acknowledge that with patients, and we laugh about it, and we talk about holding each other accountable, which I think sometimes is a really important part of gaining that trusting relationship. And then again, we want to re-emphasize well-being. Again, talking about, your weight and nutrition is one part of you. There's so much more to you that we need to talk about that helps you have a functioning body that does the things that you want to do. When they want guidelines, I'll use the dietary guidelines from the U.S. Department of Health and Human Services. There's things I like about this guidance and things I don't like about this guidance. I don't love the healthy eating pattern wording. I think that it might be better to use words like nutritious, because healthy and unhealthy has connotations of good and bad, which then sometimes can spiral into individuals feeling stigmatized based on eating good or bad foods, or feel guilty about eating good or bad foods. But what I like about this is that it's less about the number of servings anymore, and just kind of what to aim for in terms of, when you're having grains, try to have whole grains. When aim to have fruits, aim to have vegetables and a variety, and those should be dark green and red and orange. So thinking about a variety of foods, honestly, is the biggest take home from this, as well as thinking about foods that may be more nutritious to focus on as opposed to other foods that may be available. One of the things that comes up a lot is availability of food and food insecurity. And certainly we know that chronic stress, as we talked about, contributes to overall health issues, and certainly social determinants of health, and food insecurity being one of those, is a major contributor. And so one of the things that's important to remember that I honestly often forget, because I am privileged and I have access to fresh fruits and vegetables, we can eat canned and frozen vegetables and fruits and get benefit from those as well. And so just remembering what's going to be available for our patients, and culturally what's going to be appropriate, becomes really important as well. When I'm talking more generally about nutrition in the context of overall health, some of the things that I'll emphasize, and for which there is some degree of evidence are beneficial, are family meals. So having that time when individuals eat together with their family, remembering that families come in all different ways. And so not necessarily defining family, but defining who they live with, or friends or partners or others in their lives that they can eat with. Remembering to eat consistently throughout the day. Oftentimes I'll have patients who don't eat anything all day and then have large meals at night. And that has negatively impacted their health, their well-being, and oftentimes is associated with a sense of guilt, as they see that as a binge. And sometimes it is a binge, and ultimately can lead to binge eating. Having a variety of foods becomes really important, trying to avoid restricting, obviously, unless they have a peanut allergy where they're going to anaphylax, avoid restricting any particular type of food, avoiding making drastic changes. I always joke with patients, like, if you decide that from now on you're going to stand on your head, you're not going to be able to stay there very long, because it's so upside down and backwards. So thinking about doing something small is much easier than trying to stand on your head after you've lived your whole life on your feet. Don't let perfection get in the way of good. I'm the worst offender of that, and talk a lot about that with my patients, of like, perfectionism is really hard. We want to be perfect. We see all these things on social media that look perfect, these beautiful plates and meals that everyone's putting together. And ultimately, we have to live, and we have to get energy into our bodies. And there's a variety of different ways to get that energy into our bodies. There's no such thing as perfect. Another thing that I emphasize a lot is that all food has benefit. Chocolate cake has benefit. We eat chocolate cake with friends. It's social. Sometimes we have a soda because it tastes good and we want a little caffeine boost. There's no such thing as a food that doesn't have benefit. And then just appreciating your body for all it can do. That's where I talk about the concept of body neutrality. I use that often with my patients who are experiencing gender dysphoria and are really uncomfortable in the body that they're living in, and can't necessarily proceed yet to make changes that they may need to make in the future. So we talk about other things that their body is good for. They have legs that give them the ability to walk and run, arms that make them able to lift and hug, hands that give us the ability to grasp or grab, and then a face that gives me the ability to see and taste, or ears that give me the ability to hear. One of the important things, of course, is to be mindful and pay attention to individuals that may have disabilities or may not have full function of all their body parts, but reminding folks that our bodies do amazing things. Our bodies are not there to be on display for everyone to judge. Our value doesn't come from our size and our shape. Our value comes from the things we do. And then taking that strength-based approach with patients can really help them identify those strengths and help them refocus from thinking about that body and that body size to all that they can do currently and maybe some things that they want to do in the future. Finally, choosing our words becomes very important, especially in your electronic health record. We know that patients see obesity and morbid obesity and adiposity as very stigmatizing. And now that patients have access to medical records, as they can see their problem lists in their electronic health record, for example, or diagnoses, or they get a printout with their diagnoses on it, or get explanation of benefits with their diagnoses on it, as much as we can avoid using more stigmatizing words in that context, because that becomes really important. Thinking about using words like larger or smaller bodies, elevated BMI, elevated weight for height, weight increasing faster than height. Many individuals prefer fat or fatness as a description for larger bodies. I, again, as I mentioned, try to avoid referring to size at all and really refer to overall well-being, and the well-being part of that being nutrition. So like, do they eat consistently 3 or more meals a day? Are they drinking water? Do they get some fruits and vegetables here or there? So if I'm documenting what the eating patterns might be or what their nutrition status might be, I'm more likely to document that. And then more likely to document if there is elevated cholesterol or elevated blood sugars or other things that I'll identify through the biomarkers, which are meaningful and more meaningful than the BMI that we're using to overall, unfortunately, label patients, often inappropriately related to their health. So I wanted to give time for questions. I can see Q&A and chat going, and really welcome discourse and discussion. This is a difficult topic to cover in an hour and difficult to ensure that we allow time for questions. So I tried to touch on various elements. I didn't cover much related to some of the differences that we see related to race or gender when it comes to weight stigma. And I think that would be a great future topic for us to consider for NSEED. But at this time, I'd like to pause and just welcome questions and comments and go from there.
Hi, Dr. Perry. So let me just give folks a little bit of next steps. So I'm going to read the questions that you've presented to Dr. Perry, questions that we're unable to get to. As you know, we have 6 minutes left before we wrap up this webinar session. We will send those to Dr. Perry via email. She'll take some time to respond to those, and then we'll get those sent out to you over the next few weeks. We will also have slides sent out to you at the end of the presentation, so you'll have those for your records. And then we will also have this recorded presentation available on the NC Training Center, which will be at www.ncdus.org within the next month. I'll go ahead and start reading some of the questions that have been posed. The first question asks, the history of using BMIs was done for political reasons. This is part of the problem causing burnout in healthcare. Political forces using health for their own agenda. It is not physicians in general who promoted BMI. Please address this physician blaming issue regarding BMIs.
Yeah, I think that's a really important point, and thank you for bringing that up. First of all, I think burnout is a huge problem in medicine and have experienced some of it personally myself. There are a lot of pressures on us as providers to provide care that's not necessarily evidence-based, but that we have to provide in order to essentially essentially get reimbursed for things. I know that Medicaid, for example, in North Carolina, for a while anyway, was requiring that we put BMI status on every physical exam. So absolutely, there's a large political agenda. I'm going to avoid commenting on it only because as an individual who represents a public institution, I need to be cautious and careful, but we'll acknowledge that there are pressures that are put on physicians to to follow some of these recommendations that aren't necessarily as evidence-based as we would like.
Thank you, Dr. Perry. What do we know about the construction of social media algorithms?
So we don't know very much. Most of those are proprietary. So, and there's ongoing debate about how much of that should be monitored or shared publicly, as well as how much of that should be essentially regulated. So right now, a lot of social media platforms are quite proprietary about their algorithms because, again, it's financially probably an incentive for that. And so until we have more information, what we know is that there are algorithms that exist and that they exist to guide individuals to postings or through searches based on their previous searches. And then also there are algorithms that try to filter out certain overtly, for example, racist or gender biased or other statements that are being posted. However, it's very limited how much of that is done. And again, it's proprietary, so we don't know as much as we wish and should know.
Thank you very much, Dr. Perry. The next question reads, when looking at health and primary care pediatrics, do you use ACEs, ASQ, PHQ-9? Our clinics look at the whole patient.
Absolutely. We would absolutely use PHQ-9. We don't use, at least in our clinic, we don't use ACEs, but we do screen for social determinants of health. In the adolescent medicine clinic, which is a specialty clinic, we use the PHQ-9, the GAD-7. We use the SCOFF or the EAT26 as an eating disorder screener, and we use the CRAFT also for substance use screening. I hope that answers that question. But I do think it's important as much as possible to use validated screeners and also to ensure that adolescents in particular have confidential time to answer those questions.
Thank you. The next question asks, what is CRP?
That CRP, thank you, is C-reactive protein, which is an inflammatory marker. So if someone is in a state of inflammation, their CRP will be elevated. That might happen if they have an infection, but it also happens in individuals who are under even chronic stress, and having chronically elevated CRP or being chronically inflamed causes damage to our vascular system and other organ systems.
Thank you. Is increased CRP a result of discrimination or a function of the higher BMI?
So what we know is that individuals may have a higher CRP associated with an elevated BMI. We don't know that the BMI is causing that. It could be related to other factors that are also associated with an elevated BMI. There may be other genetic factors that an individual has more insulin resistance and therefore is prone to gaining more weight easily, and then may also be prone to having an elevated CRP. So we oversimplify it as the bottom line. We really can't say that BMI causes an elevated CRP. We can say there's an association. There's also a very strong association with stigma, whether it's weight related or other forms of stigma, and elevated CRP.
Thank you. And I'll read one last question.
Thanks for these great questions.
A lot of treatment plans for binge eating disorder are accompanied by weight loss goals and diet recommendations, which can further exacerbate binge eating and delay recovery. How can we overcome this or advocate for weight neutral approaches to BED treatment and recovery?
Yeah, I mean, I think I sort of feel like you answered the question in the way that you asked it, and that we do really need to ensure that when we're treating particularly binge eating disorder, that weight goals are not part of the treatment plan, that the goal ultimately is to help that individual develop eating patterns that they feel they're in control of, and that they feel they're able to enjoy food and get back to more consistent, what would be considered normalized eating patterns. I say that too about most eating disorders. So patients that have anorexia, obviously we monitor their weight and that gives us a sense of the trend, but ultimately what's most important are thoughts and behaviors. And so individuals that have any type of eating disorder, really better understanding their thoughts and behaviors around food and their thoughts and behaviors around their body tells us where they are overall in their stage of recovery.
Thank you so much, Dr. Perry. We are now at the end of our hour. I wanted to thank you all for coming to today's webinar with Dr. Martha Perry. We truly appreciate all of your questions and your attentiveness. Dr. Perry, do you have any words that you'd like to say before we close out?
No, I wish we had more time. I would love to hear more questions. I should have left more time for that. But please feel free to email me or email others, and I'm happy to engage more. And also would welcome feedback about how we can continue to present these issues in a way that's going to be meaningful for everyone that is a part of our healthcare system and a part of supporting individuals with eating disorders or at risk for eating disorders.
Thank you so much. And as we mentioned before, these questions that were unanswered will be sent to Dr. Perry. She'll take time to reply, and they'll be sent to you via email over the next few weeks. Thank you once again for your time, and we appreciate you joining today. Thank you.
Thanks, everybody.